Hey everybody, today we're going to be going over Chapter 32, going over spinal injury and spine motion restriction. In this chapter we're going to go over the anatomy and physiology of what a spinal injury is, as well as the anatomy of the spine, care for patients that we suspect to have spinal injury, guidelines that we take when taking spine motion restriction or SMR, techniques for this, as well as some considerations that you want to take as well. Now, things such as vehicle collisions, recreational activities such as water skiing, snowboarding, ATV riding, falls, all of these activities pose a potential risk of causing severe spinal injury. The issue with this is if you have any kind of spinal injury to the spinal column and to the nervous system, it can affect the patient's ability to not only be able to move and control various aspects of their body, but able to feel those things as well. So you want to make sure that we handle them in a safe manner to prevent any further injury to the spine. Now, the nervous system has two parts, two major functions, both communication and control. And they do this through afferent and efferent neurons. One's with an A, one's with an E. Your afferent neurons communicates everything that you feel. When you touch something hot or something cold, it communicates it up to the brain. It then sends a message back down through the spinal cord through the efferent neurons that tells you whether you need to move your hands off of that substance or if it's okay, whatever. Now, the structural divisions of the nervous system is your central nervous system. This comprises of your brain and the spinal cord. And your peripheral nervous system is everything that's located outside of it. So once it branches outside of the spinal cord into the nerves, that is when it's your peripheral nervous system. Your autonomic nervous system is partly independent of the rest of the nervous system. This comprises of your sympathetic and parasympathetic nervous system. Remember, you have your voluntary muscles or voluntary nervous system where you're able to control the activity of skeletal muscles. So being able to move, being able to talk, or have a drink. Your sympathetic parasympathetic nervous system. These are those involuntary muscles and hormonal glands. Your sympathetic nervous system, if y'all remember back to previous lectures, your sympathetic nervous system is your fight or flight. Your parasympathetic nervous system is your relaxing portion. Your spinal column is divided into 5 parts. You have the cervical spine, the thoracic spine, your lumbar, sacral spine, and your coccyx. Your cervical spine is the first 7 vertebrae that form the neck. This is the most mobile and delicate portion of your vertebrae, and injury to the cervical spine or C-spine is the most common cause of spinal cord injury. The thoracic spine is the next 12 vertebrae directly below the C-spine. This composes your upper back. Your lumbar spine is the next 5 that form your lower back. Your sacrum or sacral spine is the next 5 vertebrae that are fused together and form the rigid posterior portion of the pelvis. And then your coccyx or tailbone is 4 fused vertebrae that form the lower end of the spine. Now this is the principal support system of your body. Your ribs originate from it to form your thoracic cavity, and the rest of the skeleton is directly or indirectly attached to your spine. Because light touch and pain are carried by different tracks, the patient might not feel light touch, but can feel the pain of a pinch. This finding can be present if the spinal cord is partially injured. Your motor tracks carry impulses to the same side of the body. So if I'm having an issue controlling being able to move my hand on the right side, it means the right side of my spine has been damaged. Whereas pain is on opposite sides of the body. So if I get stabbed or if I get shot or whatever on the left side of my body, once again it's the right side of my body that's affected or that's feeling it. And then light touch tracks such as lightly touching your desk is on the same side of the body as well. Now, some common mechanisms of spinal injury, like we mentioned before, is your vehicle collisions. It's the most common cause. 85% of the patients that we will see with this possible spinal injury will not present with a neurological deficit, and that's why you want to make sure that you do a proper assessment of these patients. If you don't handle them properly, it could potentially result in extenuating their injury. And a patient could have a spinal cord injury without a spinal column injury. The spine is particularly susceptible from injury from compression, where the weight of the body is driven against the head, commonly seen in falls and diving accidents, where the person's head impacts the object first. Flexion is when there's a severe forward movement of the head in which the chin meets the chest or the torso is excessively curled forward. Extension is a severe backward movement of the head in which the neck is stretched. Rotation is lateral movement of the head or spine beyond its normal rotation. Lateral bending is when the body or neck is bent severely from the side. You can have a distraction injury where the vertebrae and spinal cord is stretched and pulled apart. This is common in those in hangings. And then penetration is injury due to some type of gunshot, stabbing, or other penetrating trauma that involves the cranium or spinal column. You must suspect spinal injury in any case that might involve one or more of these mechanisms, even if the patient appears to move normally. Injured vertebrae that are still aligned but unstable can become unstable at any moment and damage or sever the spinal cord. Although a patient complaining of pain to the spinal column likely has a vertebral fracture or injury, they could have a vertebral injury without a spinal cord injury. Conversely, a loss of motor or sensory function indicates a spinal cord injury. However, it does not imply a vertebral fracture or injury. A patient that is presenting in spinal shock can present with complete paralysis that might resolve within 24 hours to several days after the injury. Complete spinal cord injuries is when the cord has been completely transected. This patient will lose all function, all motor, and all sensory capabilities below the site of that injury. When a patient does have spinal shock, they're losing all sympathetic control. Male patients that are suffering from spinal shock may have an involuntary erection of the penis called a priapism. Treatment for spinal shock is much the same as for any other types of shock. SMR must be applied, and the patient must be kept warm because of the increased heat loss due to peripheral vasodilation. These patients will also present with warm and dry skin, a normal pulse rate. However, they will be hypotensive. With an incomplete spinal cord injury, only certain aspects of the tracts will be affected. Not every tract will be affected, so only certain aspects of the injury will be present. You can have what's called a central cord syndrome, anterior cord syndrome, or Brown-Séquard syndrome. With central cord, let me get my clicker. Only the center, the medial sections of the cord is affected. Anterior cord is the back half, or excuse me, the front half, and then Brown-Séquard, only one half of the cord is affected. In central cord syndrome, the patient presents with a loss of motor function or weakness and loss of pain sensation to the upper extremities, while motor and sensory functions remain normal in the lower extremities. In anterior cord syndrome, the patient loses the ability to feel pain and crude touch below the site of injury, and likely experiences the loss of motor function below the injury site. However, these patients retain the ability to feel light touch above and below the site of injury. In Brown-Séquard syndrome, the patient loses motor function and light touch sensation on one side of the body while retaining pain sensation on that same side. On the other side of the body, the patient retains motor function and light touch sensation while losing all pain sensation. When assessing patients that are suspected of a spinal injury, first thing you want to do is to determine your mechanism of injury. This is based off of your dispatch. Was it an MVC, a fall, pedestrian versus vehicle, penetrating trauma, hangings, some type of diving, electrical injury. Once you arrive at a collision scene and find the patient walking around or sitting in the back of a police car, this may not necessarily rule out the possibility of spinal injury, especially if there's an incomplete spinal cord injury or a vertebral injury. Oftentimes, a patient with a stable spinal injury does not exhibit signs and symptoms consistent with injury to the spine. However, improper movement by either the patient or the EMT can potentially cause the stable injury to become unstable, thus resulting in permanent neurological damage or even death. This evidence, such as front end damage with the driver's side windshield fracture, should create a high index of suspicion that the patient was propelled forward in the crash and struck his head on the windshield. This would likely have caused the head and neck to bend forward during the forward moment and then bend backward and hyperextend during the rearward motion. Both motions are significant mechanisms of injury that may not be suspected if the damage of the vehicle were not observed. An injury to the cervical spine in the 3rd to 5th cervical vertebrae may injure the phrenic nerve that controls the function of the diaphragm. Because the diaphragm provides more than 60% of the effort to breathe, the patient can develop respiratory failure and require ventilation. If you do have a patient with a suspected spinal injury, you do not use the head tilt chin lift. You will take immediate inline stabilization and only use the jaw thrust to open up their airway. Go through to your primary assessment. Remember that spinal cord damage from a C-spine injury can block nerve impulses traveling from the brain to the diaphragm and intercostal muscles, which are necessary for adequate respiration. Once you take manual inline stabilization, do not remove it until indications for motion restriction have been not been found, or full spine SMR has been accomplished. We'll do this on patients with positive mechanisms of injury who has an altered mental status, painful distracting injuries, or if they're unable to communicate with you. The mental status of a patient with a spinal injury can range from completely alert and oriented to unresponsive. Based on your assessment findings, categorize the patient as either a high or low priority for emergency care or transport. If the patient is unresponsive, responsive but cannot obey your commands, or displays an abnormal respiratory pattern, or obvious signs of spinal injury such as numbness or paralysis, you must consider the patient a high priority for emergency care and prompt transportation to the highest level trauma center based on your destination proposals. Some protocols will allow you to instruct the patient to perform self-restriction, which is to ask the patient to restrict or prevent his movements to keep his head, neck, and spine in proper alignment. While you're going through your secondary assessment, if this has not been found, You are to maintain your inline stabilization, go through your full head-to-toe assessment. After assessing the neck or the C-spine, this is when you can apply your C-collar. Always make sure you assess for pulse, motor, and sensory function both before applying the C-collar and after fully mobilizing them to the patient to the board. When you roll your patient up to check their posterior, you can go ahead and place the patient onto a spine board, pending you are going to place them on the board. Evidence of deformity, tenderness, contusions, lacerations, punctures, or swelling to the spine or around the spine should heighten your suspicion that a spinal column injury could potentially exist. Go through, get your baseline vitals. Hypovolemia and spinal cord injury can both be present in the same patient. Therefore, be cautious in your assessment because a spinal cord injury may prevent the typical signs of hypovolemic shock from occurring. If they are hypotensive and tachycardic, you need to suspect bleeding as another type of shock. However, if they are hypotensive and have a normal pulse, suspect neurogenic hypotension. Go through and get your history. Some questions that you might want to consider asking is, do you have any pain? Where does it hurt? Can you move your hands and feet? When was the onset of your pain? What was the cause? Did you fall or have some other type of injury? Have you moved or did someone move you before our arrival? And were you able to get up and walk around before our arrival? Go through, check for signs and symptoms. Spinal motion restriction should be based only on physical assessment findings and not solely based off the mechanism of injury. So if they have any tenderness along the spine, soft tissue injuries, pain independent of palpation or movement or associated with movement, go ahead and take spinal precautions. It is imperative to recognize that a patient's lack of pain in the spinal column or his ability to walk, move his extremities, and sensations do not rule out the possibility of spinal column or incomplete spinal cord injury. After a thorough assessment of a patient with blunt and penetrating trauma, these indicators show that the patient should be transported using with spinal motion precautions. Such as GCS less than 15, suspected TBI, confusion, paralysis, weakness, numbness, and tingling. Any deformities, influence of drugs or alcohol, distracting injuries, anything along these lines would be indication for spinal motion restriction. Now, with anything that we do, there's always complications. If we lay a patient supine, then they may not be able to breathe adequately. It may be more complicated to provide positive pressure ventilation because now we can't provide head tilt chin lift. The respirations may be shallow with little movement of the chest or abdomen because of gravity pushing down on top of them. They may have paralysis or paraplegia. Hemiplegia would be some other complications of spinal injury. Inadequate circulation, vasodilation leading to hypotension and poor tissue perfusion. When caring for them, you want to make sure that you are taking standard precautions. If the patient is complaining of severe pain to the neck or C-spine or the head does not easily move, maintain the head in the position found. If it is turned to the left and when you try to move it back, if it's not able to move, don't force it into position. Secure it in that position found. Insert an OPA or NPA as appropriate. Remember though, if you have any kind of facial trauma or suspect a fractured skull or cranium, do not insert a nasopharyngeal. Maintain an O2 stat of at least 94%. Prepare to suction without turning the patient's head. Go through and assess PMS. Make sure that you apply your C-collar properly, because if it is not sized properly, it can cause more harm to the patient by compromising the airway and further aggravating a potential spinal injury. It is safer to err on the side of caution and provide spinal motion restriction if spinal injury is suspected. Spinal motion restriction devices can always be removed at the ED after the physician or radio x-rays determine that no spinal injury exists. After you place them on the board, make sure you reassess PMS, transport your patient. When you go through reassess, make sure that you assess everything, including PMS at all times. Reassess your complaint, so on and so forth. Because a spinal injury is rarely an isolated injury, make sure you look for signs of hypovolemic shock. Their skin will become pale, cool, and moist. Blood pressure falls, heart rate increases, and the patient's mental status decreases. Remember that a decreasing level of responsiveness is an early sign of head injury. Alright guys, we're going to go ahead and take a break here. Stretch your legs, get something to drink, whatever you need to do. When we come back, we'll go over the guidelines for spine motion restriction.